Well, hello and welcome everybody and Happy New Year. I'm so delighted today to serve as an opening act on this absolutely wonderful, exciting ISSM webinar on religion and sexuality. My name is Omar Rahim. I'm a urologist and sexual medicine specialist at the University of Chicago. I also the incoming ISSM webinar chair. I'm very happy to serve in this role. It's my really extreme pleasure today to introduce this topic, religion and sexuality. I think we're all going to hear wonderful state-of-the-art information, education on how religion would play part in sexuality and someone's social performance. Next slide. I think ISSM has been around over the last several decades. Really the vision of ISSM is that every human being has the right to a healthy and satisfying sexual life. Next slide. The mission and purpose of ISSM has been stated in this slide, and as you can see, ISSM has been around for the last 41 years since it's been founded in 1982. The whole idea is that we want ISSM to cover the whole field of human sexuality, including male, female, transgender, and all important aspects and topics of sexual health. We want it to be the most respected and trusted source of information, education, and professional development on health, sexuality, and human health and sexual life. For example, and in the spirit of webinars, I think today's webinars is a perfect example of how we deliver the virtual webinars, trying to promote highest state-of-the-art educational material in sexual education and so forth. Today's webinar has been really wonderful to see over 500 people registered for this webinar. And it's the first one of the year, so we're looking forward to all of you interacting and be present for this webinar. ISSM has 7 affiliated societies. As you can see from this slide, they are represented across different parts of the globe, and all these affiliated society has active, involved roles. They serve the needs for regional and really needs of their communities. The role of ISSM has to be integrate all these societies and activities worldwide and provide a forum and mechanism in which we deliver the highest education material on sexual education and health. We do this through different platforms of education platforms. Today's webinar is an example for that. Obviously, since COVID has changed the way we deliver medical and sexual education, but the journals has been really wonderful to see 4 platform flagship journals. The Journal of Sexual Medicine, as you can see here, is the initial journal and represent state-of-the-art education, research, and basic science research. Sexual Medicine Reviews has the highest impact over 5 among all the sexual medicine journals. We have an open access sexual medicine journal. And lastly, we have the Video Journal of Prostate Urology, which is largely serving surgeons, providing highest innovative surgical techniques that aim to address sexual health problems. Today's webinar is going to be moderated by esteemed colleague, Dr. Tali Rosenbaum. Dr. Rosenbaum, she's from Israel. She's a certified sex therapist and an author, and she tells me she trained initially as a pelvic floor physical therapist, and she had to rebuild herself as a expert in sexual health. She has a tremendous experience in dealing with a variety of sexual problems and also cultures. She has co-authored multiple chapters and textbooks, including a book entitled The Overactive Pelvic Floor, which is an exciting book to read, I'm sure. The second book is I Am For My Beloved, a guide to enhance intimacy for married couples. She's currently involved with the ISSM committees. She's currently a committee member of the educational committee of the current ISSM society, a valuable member of the team. And additionally, she published over 40 journal articles, again, in different field of sexual and culture. I think we're all excited to have you here and listen to you moderate the session today, Dr. Rosenbaum, as well as other esteemed faculty and speakers. Without further ado, I'd like to pass it on over to you and take it from there.
Thank you very much. I'm honored to be asked to co-moderate this webinar with my esteemed colleagues today, with Dr. Michael Critchman, and we'll be hearing from Dr. Caleb Jacobson later. So just to go over some housekeeping, we have a Q&A section, and we hope to be able to have a panel together and talk about some of the questions that come up. So please submit your questions to the Q&A. So I'm very happy to introduce this important topic. If we can get the slides on, that would be great. So we've all been raised on the biopsychosocial paradigm, and we value that this model is very important to sexual health, and particularly biological, psychological, and social factors all combine around sexual functioning. But the factors that are related to the social components don't often get very much attention. And they're also very important because not only are they important in sexual functioning, but they're important in shaping our attitudes and our beliefs around sexual values. And the social component obviously includes culture and religion, which aren't exactly the same thing, but they do impact each other. And my colleagues and I do discuss this in this paper in the current sexual health reports, which is entitled The Impact of Culture and Ethnicity on Sexuality and Sexual Functioning. Next slide, please. So sociocultural factors are important because they inform many things. They inform how sexual information may be obtained, decisions regarding the appropriate age for first intercourse and what are the appropriate sexual behaviors. They may inform our attitudes about gender and about sexual orientation, and also what's normal about intimate relationships. How are they formed? Are they formed by meeting each other? Are they formed online? Are they developed through arranged marriages? And how the concept of desire is thought about. And also, culture determines our attitudes about bodily autonomy and consent. The age of consent, if you Google age of consent in different countries, you'll get a list of the legal ages for consent, which in the USA and many Western countries is 16. In Angola, Africa, the age for legal consent is 12. And in South Korea, it's 20. So that already tells us a lot about differences culturally. Next slide, please. But speaking specifically about religion is really important in sexual development because, well, let's look at values and traditions regarding the meaning of sex, rituals around sex and practice are essential parts of many religions. Traditional values might restrict access and knowledge about sex. Restricted and limited sexual behaviors may later impact sexuality and sexual functioning. Often conflicts between religious values and sexuality might be a source of guilt and shame. And also, at least what I find in very religious populations, that sexual behaviors which are generally considered normal, such as masturbation, for example, might be more likely to be pathologized as addictive, even if their frequency is normative. Next slide, please. So as health professionals, we must provide a culturally informed approach to care within an ethical framework that imbues respect, understanding, and tolerance. But at the same time, we need to manage our own reactions to situations which might appear to challenge our understanding of sexual and reproductive human rights. So this is a lot to think about. And with this, I would like to hand this over to Dr. Michael Critchman. Michael Critchman, MD-CM, is the Executive Director of the Southern California Center for Sexual Health and Survivorship Medicine. He is the Clinical Health Professor at the University of California, Irvine, Division of Gynecological Oncology, and the Medical Director of Ann's Clinic, a high-risk program for breast ovarian cancer survivors. Michael.
Thanks, Holly. Wonderful intro. And we're going to take the next little while to build upon some of the thoughts and kind of do a little bit of a deeper dive on some of the, the larger religions that clinicians may see. Again, I wanted to reiterate my thanks to the ISSM for addressing this topic. And again, I want to put it in some framework to recognize that, we can certainly do hour-long talks on each specific religion, the nuances and the specific customs as well that impact sexuality and impact the ability to provide comprehensive care. I wanted to make reference to a CME article, which is a primer on sexuality and religion. It is in the Journal of Sexual Medicine. And it really does a little bit of a deeper dive. So again, putting this into context, we wanted to kind of go over some of the nuances and some of the details. And as we progress through the slides, you'll see that there are some very common themes. And again, when we have some case studies after Dr. Caleb Jacobson speaks after me, we'll have to try and address some of the clinical pearls of how we can address some of these nuances in our clinical practice. Next slide, please. So we're going to jump right in. We'll talk about Catholicism. And again, remember, this is just a general overview. You'll see some common themes throughout all of the religions as we progress in the slide set. So all behavior really is in harmony with nature, intrinsically moral and good, should be pursued. Anything that is contrary to nature, really with very religious doctrine, may be morally considered evil and should be avoided. And again, the focus is really on the couple, marital life, focus on procreation and the unitive aspects of a relationship. Sexual activity within a marriage is really considered a gift of God, an act of love, whereas outside of the sanctity of marriage, it is really an area of concern. Chastity until marriage really is viewed as a virtue, whereas contraception may be considered intrinsically wrong. Sexuality is very closely linked to contraception. And again, conception is really the ultimate goal of sexual activity. Same-sex behavior really is considered a sin if it is only acted upon. So again, homosexuality in and of itself is not considered a sin unless acts are taken. And again, as Tali had mentioned earlier, again, self-stimulation or masturbation really is frowned upon, as the focus of sexual activity really should not be for pleasure in and of itself. It should really be on procreation. Next slide, please. So if we look at the issues related to Judaism and sexual function, we see that in the Jewish religion, as well as others, we have a variety of different branches. We'll have the ultra-Orthodox, the Orthodox, conservative, and more of a reform or liberal view. And again, as the branches of religion vary, so do their beliefs in sexuality. And this can be very important when you are doing a clinical evaluation of a couple, really understanding how detailed, how holdfast they are, how religious they are, can be quite important. Very often in the Jewish faith, you can consult religious leaders, ask for guidance, ask for permission for certain activities. And again, I think this is one important caveat. As a sexual medicine clinician, it's important to understand the religious background, and again, perhaps sometimes engage religious leaders. Very often in my clinical practice, I'm asking for them to contact their spiritual advisor, their rabbi, or it's their priest, again, to get more information about how they can further along their journey in sexual wellness, as well as maintain fast to their religious beliefs. Again, in Judaic culture and religion, traditional heterosexual marriage is what is the ultimate goal. More liberal position, gay rabbis, same-sex unions have been performed where more of a conservative approach, they still hold bans on gay rabbis and same-sex unions. Again, the common theme, sex outside of the marriage is prohibited, masturbation prohibited, no premarital sex, and again, the concept of modesty, the sanctity of family and purity values as well. Many may be familiar with the concept of the mikveh. After menstruation, a woman must go to the mikveh or ritual bath again, and there are a variety of different rules surrounding menstruation and sexual activity and touch. And again, this translates into different periods of time where sexual activity is permissible. Also, in termination, if a woman's life is in danger, there can be concessions made. Next slide, please. So we look at, in terms of Hinduism, sexual pleasure makes up one of the four elements. Again, many of you are familiar with the Kama Sutra, which is an ancient text, but not just about sexual positioning. And sexual behavior is an integral part of sexual pleasure. Sensual pleasure is important to a good life. We see that, again, the same thing, premarital sexual activity. In many communities, it's discouraged and discouraged private interaction between male and females. Arranged marriage may be the norm. And again, we're seeing the issue related to homosexuality, which has changed throughout history. And again, Hinduism in 2009, Hinduism doesn't condemn homosexuality as well. Next slide, please. When we look at the Islamic faith, again, we're looking at religious texts and scripture. And again, remember that all of the doctrines and religious sexual values certainly come from ancient texts. And again, those are subject to personal interpretation as well as your personal belief system, as Tali had mentioned. Sexuality under this doctrine certainly is only permitted in the context of marriage. It isn't just about childbearing, but sexual fulfillment for both partners is certainly the ideal, and dissatisfaction can certainly be grounds for divorce. They get a little more detailed where oral sex is permitted, no anal sex or prostitution. Again, rituals also seen with sex and religion, post-ejaculation, full body ritual washing, as well as some restrictions during menstruation. So again, we see rituals, we see the issues related to premarital sex, we see again relations to self-stimulation, which is considered unlawful. And again, here we also see that termination may be permitted if the woman's life is in danger. Some things, again, we see the courtship may be influenced as well. Male and female should not be left alone to avoid issues related to lust or temptation, avoidance of seductive clothing, pornography, explicit materials. And again, we see a lot of rules related to that as well. Next slide. And the last one that I wanted to discuss is the issues related to Mormonism. And again, we see most of the doctrine from the Book of Mormon. Sex in a heterosexual marriage is seen as ordained by God. Again, the common theme, no premarital sex, fidelity, the sanctity of the relationship and marriage, refraining from pornography, masturbation, again, one of the values to avoid inappropriate sexual thoughts. We see the theme of chastity taught throughout all ages, with a prohibition on oral sex as well. And sex within the marriage certainly is advocated. Outside, a variety of things are prohibited. And again, we see that members who self-identify as gay or lesbian may be accepted in communities as long as there's no activity as well. But activity between two of same-sex partners is considered against the traditional doctrine from the Book of Mormon. So with this brief introduction, really meant to get you interested in further do research in certain things, I'm going to hand the stage over to Dr. Caleb Jacobson. He is a clinical psychologist, sex therapist, and a Bible scholar. He is the chair of the ASEC Special Interest Group on Sexuality and Religion and is the president of the School of Sex Therapy. It's my honor and pleasure to introduce Dr. Caleb Jacobson. Thank you so much for joining us today.
Well, thank you. And it's really my honor to be here. I want to thank the ISSM for putting on this webinar, and I really appreciate the invitation. Thanks very much to Tali and Michael. And I'm thankful to have so many friends and colleagues who are joining us on this webinar for this very important topic, one that I think is sometimes overlooked in sexual health for many reasons. And for those of you who don't know me, I did doctoral work in both clinical psychology and in Hebrew Bible and biblical archaeology. So this intersection between sex and religion, I think, is so very important, and spend quite a lot of time researching, writing on the topic. Although this sometimes gets confused, this past summer for the European Association of Biblical Studies, I was there speaking on sex, sexuality, and gender. And then for the International Society for Sexual Medicine, going to talk more about religion and biblical studies. So they sometimes get crossed, but they're both topics that I really enjoy. And my practice specializes in working with clients who are religious. I often say it's an interesting paradox to be an Orthodox Jew living in Germany, working with a lot of Muslim clients from Saudi Arabia. So it's a fun intersection, and I'm hoping that you're going to enjoy a little bit of this talk and see how culture and religion really impact your clients. So I'm going to talk about the correlation between culture and religion in the development of sexual attitudes, therapist and client's perspective. So what does this mean? Well, we are going to explore the interaction and influence of culture and religion and how they impact both the client and the therapist perspectives of sex, sexuality, and gender. So you see on the slide, we got this intersection of culture and religion. That's one part of it. Then when we take that intersection and we can see how it influences both or all sex, sexuality, and gender, we can then see how it has resulted in both the perspectives of the clinician and the client. And we all recognize that religion and culture has influence on a client. But one of the things that I hope to demonstrate is just how complex these influences are. Next slide, please. I want to first acknowledge a few things concerning religion and culture, as well as the way that people practice their religious faith. I think it's important to keep in mind that within a faith tradition, there are various subcultures. Why is this important to mention? Well, because when we talk about religion, and as therapists, Michael mentioned that as we talk about religion, we could spend all day spending individual time into each religious faith, and that's so very true. And I think as therapists or as clinicians, when a client comes to us, we often have a perception of what a certain religious person is, or what a certain faith believes and practices. But yet there are so many nuances that are in subcultures within that religion, right? So we want to look at that and to use as an example, if we think about like Orthodox Judaism, an Orthodox Jew like myself would think completely different and hold completely different boundaries around sex than, say, a Reformed Jew. Or someone who is Christian and part of the United Pentecostal Church would have completely different standards in regards to sexual purity than someone from a more liberal fraction of the greater Christian faith. So it's critical to understand that these details so that we can avoid making any misconceptions about clients, their beliefs, and the impact and influence that their religious beliefs have on their sexuality. It's also important that people are impacted differently. And as we'll see by these different cultural aspects, there are cultures that are outside of the religion, societal ideas and cultural norms that are opposition to a person's religious belief. And there are also cultures within the religious community that has a certain culture and societal construct in and of itself that we'll talk about in just a moment. And that leads to the next point, which is that religious community and the way that it is practiced today can be completely different than sacred text of the religion. There can be a stark difference. An example from an academic perspective is the difference between biblical studies and theological studies. Now, obviously, the Bible isn't relevant to working with a Buddhist client or a Sikh or a Taoist, but the principle I'm about to share is the same with any sacred text in any religious community. So in academics, we have biblical studies, and this is a discipline that seeks to understand the text of the faith tradition, right? Or purely from an academic point, it is text-centered. What message did the author try to convey? My work in biblical studies and biblical archaeology, which did focus on sex, looks at the cultural background of the text, when the text was written, and tries to understand the cognitive framework of the author and the message that they were trying to present to their specific audience. And this is completely different than theological studies and the work of a theologian. A theologian doesn't really care about the cultural background of the text, and maybe not so much about what the text specifically says, as much as they're concerned with the way that we should understand the text today, or that how the text should be applied, or how that text was understood at different points and how it influenced theological thoughts. They may look retrospectively at it, that's what's known as historical theology, and see what was previously taught about a particular theological concept in the past. Theology is forever evolving, and it's done so out of necessity. Next slide, please. I really love this quote by Catholic theologian Johann Baptist Metz, who said that it's impossible to do theology with a back turned to Auschwitz. What does this mean? Well, if we take the example of theology proper, which is a subdivision of systematic theology, theology proper is the study of God. Who is God? What is the character of God? How does God interact with humanity? As a theologian, the lens in which you ask and answer those questions obviously depends upon the culture and history in which you live. So what he's saying is the way that we think about God, God's character, and the way we determine that, if we say that God is good, or God is love, or if we say that God is all powerful, how do we find congruency with that and something so horrific, so tragic as the Shoah? Now, how can we come to some type of justification between these two thoughts and these two realities? Next slide. So theology is often developed in response to what is going on in the world around us. We can see that in practical theology. We can see that in historical theology, which looks to how folks have done it in the past. And it is these theological thoughts which have influenced culture influenced by culture, and as such, it's created different sects and denominations within religious faith. We can look here in Germany at the onset of Protestantism and the cultural ramifications which led to Luther creating distinction between the Catholic Church and himself. But this is true of any faith tradition. If we compare Muslims living in Nigeria to Muslims who are living in Bali, or if we compare Jews living in India to Jews living in the US, or perhaps we compare those who are Hindi living in Nepal with those who are Hindi in Bangladesh. These are two different faith traditions that are all rooted in the same area, but neither have much to do with the sacred text of the faith. Their location, and by that, their culture, has influenced their religion and the way it's practiced and the beliefs that they have. And so this demonstrates the cultural influence on theology. Next slide, please. We also need to consider the theology itself does in fact influence culture. And we can look at that too, right? There are two ways that I really see this happening. There is the idea of theology against culture, which a lot of the colleagues here from the US may see this a lot more regularly, right? Like when we think of like fundamentalism and we think of like the evangelical support of Donald Trump or Jerry Falwell and the moral majority in the 1980s, the idea was to influence culture based upon their theological ideas and theological thoughts. People of faith recognize that in order to make a change and move in society, and we're talking modern times, it was important that they voted based upon their religious conviction or their religious ideals. And that's why we have and often see stark differences on topics like abortion or LGBTQIA topics. Interestingly, if we look at the topic of abortion itself, a fundamentalist Christian would have a completely different concept and way of viewing abortion than, say, a Jew, who would have a much more liberal concept of abortion than a fundamentalist who would not allow for it at all. There's also theology and the way that theology helps to propagate ideas of culture. So between this conflict of, the battle between two worldviews, and I know practitioners don't really like to use the word worldview. They say that sexual orientation and gender identity isn't really a worldview. However, that is the language that is used within academic circles among religious scholars. They say that we have competing worldviews. And it is the way that it's taught in fundamentalist communities, right? The word of God says such and such, but the world is doing something completely different. Or the prophet said this, but society is doing something different. Theology does indeed impact culture in a way that isn't always combative, though. If we take the example of Victorianism, and I talk about this in my book on Abrahamic faith perspectives of gender identity and human sexuality, there is evidence to support that views of sex, sexuality, and gender that were established during the Victorian era have been embraced by religious communities. Dub showed in 2015 that many religious communities still hold those exact same concepts today. Over 100 years after Victorianism, these ideas are still in practice, and it's because religion, particularly the Christian church, adopted so many of those concepts and spread these concepts through missionary activity. So the influence of Victorianism really became wide-reaching not because society adopted it. In fact, society rejected the idea of Victorianism, especially as they began to express interest in Egyptian archaeology and to see the more liberal views of same-sex interaction and sexual liberation that they had found in many of the artifacts and finds that they had during that time. But nevertheless, Victorianism spread due to missionary activity. And so the influence of Victorianism was wide-reaching, and it influenced not only the views, but also the values of society that were often replicated by the predominant religious community of the time, which was the Christian church. Research shows that the sociology of religion, with particular interest in the influence and relationship of religious belief to sexuality, particularly within the context of Victorianism, was particularly important to upholding and maintaining the influence of the Victorian worldview. In fact, the spread of that is credited by some scholars to Christian missionaries, as I mentioned, who influenced foreign communities with Victorian ideologies while working to spread the gospel. And this didn't begin with Victorianism, I should mention. This type of influence is much older than that. There are several examples. Pareles in 2017 suggested that celibacy as a religious response to homosexual desires extends well before the Victorian period. So as they see what's going on with culture, and they begin to not only influence that culture, but they begin to respond to the culture, and it influences their religious practices, religious ideas, and the way a religious community works and thrives and lives and sets their principles and doctrine and dogmas, which are not specifically found in biblical text, but are, or sacred text, but are the way that text was interpreted to respond to the world that they live in. So we can see the impact of religion on culture and the influence of culture on religion. Now, you're probably asking, how does all of this impact the client and the clinician? And to help with that, next slide, please. I want to, show this image of Bronfenbrenner's ecological systems theory. We won't go into details for time's sake because we will have some Q&A and some panel discussions. But I did want to point out a few things that you might find particularly interesting. When we talk about religion and religious community and the number of different systems that impact a person's life, right? Even if the person isn't religious, if we think about what I just discussed about the influence of theology on society and the influence of society on theology, we cannot help but to walk away without recognizing that when it comes to our government, when it comes to workplace, when it comes to our peers, when it comes to different systems that are in place all around us, we are heavily influenced by religion. I'll use the example of here in Germany, almost everything's closed on Sunday. Very difficult for me to function sometimes as an Orthodox Jew. I'm usually not working Friday or Saturday, so I'm not going shopping. But if you don't have anything in the house Sunday, you're fasting. That's kind of how that works, right? Like, so it's placing some type of boundaries and restrictions on your own life, even though I'm not a Christian and not influenced by Christian theology, but the theology impacts the society in which I live in. And so by that way, it does impact me. I'll point out a few additional things on this chart. If we take the macro system, where there's interactions among these different systems. And this is exactly what we've talked about, right? These different systems are moving and are working together. Or if we take the chrono system, where we see changes that are taking place in the environment over a period of time, in the religious community over time, like I mentioned, historical theology, which is something that is rapidly changing over time based upon what's going on in the world. We can also see that there are changes in a person biologically, and a person physiologically. But it's also important to recognize that a person and their ideas and their beliefs also change over time. So some clients who come may not have grown up very religious and became later in their life more religious, or vice versa. They may have grown up very religious, but because of situations and events, by the time they come to therapy, they aren't very religious. And so with each of these clients, even though they perhaps had the same faith tradition, the way that faith tradition has influenced them and their ideas and their conceptualization and boundaries around sex are completely different. There are a lot of moving parts. And so when we think about sex, sexuality, and gender, and if we can just reflect on the changes within this field in the last 5 years, there's been a lot of changes. Our understanding of human sexuality and our knowledge of sexual functioning and the way culture has evolved and the way that it thinks about things like gender, it's very rapidly evolving, and it's sometimes very hard to keep up, even if you're in the field. If we could just imagine what it's like for someone who's not in the field, especially someone who comes from a more religious background, it can be very difficult, and it can create a big conflict in their life. And with things like the internet and particularly social media, where you quickly encounter many of these things, the dissemination of information is so quick, it can cause a lot of confusion, and it can cause clients to be overwhelmed. And sometimes they come in overwhelmed about these things. It creates anxiety, and as such can create sexual dysfunction as well. I feel it's important for us as sexual health professionals to be mindful of that. I'm sure everyone here talks about sex all day, almost every day, right? We know all the research that's going on. We attend all the informative webinars like this one. And, we know all the big names in the field, but our clients and our patients don't. And it's okay for them to be in a different place. And we need to be empathetic and patient with our patients and their understanding and acceptance of things that are radically different than the way that they thought or imagined, or the worldview that they have grown up or been influenced by. I want to also briefly look at one other aspect of this dynamic, and that is the perspectives of both the client and the clinician. Can we have the next slide, please? This is where biases often arise on the part of the clinician and also on the part of the client. A client can very much have bias, and sometimes do, especially if they are a religious client and they are coming to a non-religious clinician. In my upcoming book on sex therapy with religious clients, I discuss this conflict that religious clients have when going to a therapist, especially a sex therapist, right? There are a number of contentions between psychology and theology for many reasons that I won't have time to go into. But there is a conflict of interest between religion and psychology that started in the late 1800s with the publication of a few dissertations out of Germany, no less, and then later on with some of the work of Sigmund Freud, who, although he was a Jew, he did consider converting to Christianity to avoid having a religious wedding. So there was early contention that influenced even his work, which created some contention from religious communities. And in many cases, it seemed like there was a struggle for which ideas would win out. It's like competing for clients, if you will. So a client could feel that going to a clinician can be problematic to their faith, because in some fundamentalist circles, they are taught that anything you needs to come from your religious leader or someone in your faith. You wouldn't want to see someone who is not particularly part of your religious community. Now, I don't want to say that they view them as enemies of their faith, but in a way, it can feel that way because they view the clinician as completely secular and opposite of everything that they believe. And then when you put into the topic of sex, right, which is so difficult for some religious clients to talk about, and they hold very stringent boundaries around, and they see folks who talk about sex openly all the time, it is a complete culture shock, and it causes a little bit of intimidation and trepidation to want to discuss that even more than a non-religious client. There's also the case of a non-religious client when they see a religious clinician. Oftentimes, these clients feel that maybe the clinician is trying to impose ideas upon them, or when advice is given to the client, they feel that it could be repressive or that the clinician is trying to convert them, if you will. But there is that underlying bias, regardless of how true it is or not. Next slide, please. I want to look at, for a minute, the clinician perspective. And you have non-religious clients or non-religious clinicians with religious clients. And a lot of bias shows up in this area. I talk about this in the new book. I identify 3 different forms of bias that come out. The first one is the therapist above the client. That is when the therapist has a sense of superiority over the client. Like, this client has some really primitive views that, I need to help him work through. And so this kind of manifests as like condescension towards the client. There's also therapist as the client, when the clinician projects their own experience onto the client. And so perhaps they feel that they need to rescue the client from their destructive religious beliefs. Finally, there's the therapist against the client. And this is when the clinician views the client as the embodiment of any religious trauma that they previously experienced. And so this manifests itself as hostility and resentment toward the client. There are also situations where you have a religious clinician and a non-religious client. This can come up with a lot of values when the client says things that are counter to the clinician's religious beliefs and backgrounds regarding sex, sexuality, and gender, or when, and this is something that therapists must, and clinicians altogether, must check and keep conscious of when working with clients who have different beliefs and ideas. So let's wrap this up in the next slide and what we can take home. And I'm list 3 things here. First off, it's important to remember that religion, even within a particular faith group, is heterogeneous, right? There are great distinctions in between each and every religious group, and we need to be mindful of that. So when we have a client, Michael's slides earlier showed thoughts in the Catholic community and thoughts within the Mormon community, which there are distinctions. And even within those communities, there are even further distinctions. So we need to be mindful of that when a client comes in and says, oh, I'm a Christian, or oh, I'm a Buddhist, that doesn't mean that they have the exact ideas that we imagine or that we understand that faith to have. And so it's important for us to ask questions about what they believe, where they are in their faith journey, how they understand sexual health topics. The second thing is that line between culture and religion is indistinct. It's sometimes easier to do a flow chart and say religious, socioeconomic, cultural, when the fact is that all of these elements are really well connected. So to finalize this, I would say that a general understanding of a client's religious belief is paramount in the assessment and also in the intervention. It's important in assessment to understand why a client may have a particular sexual dysfunction or sexual issue that they're dealing with or struggling with areas such as sexual orientation or gender identity. But it is equally as important to understand the client's religious thoughts and how their thoughts have been informed by their religion when recommending certain types of intervention. Because the last thing we would want to do is to recommend intervention that could be counter to their belief system, in which case they'll simply, most cases, ignore it and then not try to seek any help any further. So thank you very much, Michael. Thank you very much, Tali. And thank you very much, everyone, for listening.
Michael, do you want to go ahead and ask some of the questions? We'll do some Q&A and then we can go on to some case studies.
Yeah.
And just thank you very much, Caleb, for that awesome presentation. That was amazing. Thank you.
I'm going to just you know, and again, a whole variety of different questions. I think, you know, one that came about really is about the concept of nudity and sexual activity. Certain religions have prohibitions on it with associated guilt, shame, and its impact on the relationship, and causes some marital discord. So I'm wondering if both you and Caleb would mind commenting on the concept of mismatch. I was taking some notes and I love the concept that Caleb was talking about your faith journey. And your journey changes, I think, as you change, as medical history changes, as your life experience changes as well. But I'm wondering, Caleb, if you are seeing one client and you're hearing that there's, you know, we very often talk about desire mismatch and frequency mismatch. But what about the concept of religious faith mismatch and religious journeys not transecting? How would you address that in more of a clinical practice? So when one person is more liberal and the other one is much more conservative, and then there's this impact of dissatisfaction in the relationship. They hold fast to their marriage beliefs, but how do you incorporate that in kind of discussion in therapy?
Yeah, so actually this comes up quite often, right? Like, you know, for example, I'll have a Muslim couple who the wife prays 3 times a day and the husband's like, I don't even know if I believe in our faith tradition. And so this does cause conflict. Or, you know, we see this a lot with Christian clients who, you know, maybe one partner is religious while the other one thinks it's okay for them to do things like look at pornography or do sexual practices that the other thinks is forbidden. I think the key to working with religious clients on these ideas is to uncover the client's sexual values. So while they often hear one thing taught or one thing preached regularly, they've never actually taken the time to cognitively work through that to decide if that's a value that they hold to themselves, or if it's just something that they hear regularly within their community. So I try to work with a lot of my religious clients on, okay, your faith says this. What do you say about this topic? And a lot of times they haven't thought about it. Sometimes they'll go to the topic, especially if it's a Christian or a Jewish client, they'll say, well, the Bible says this, in which case it's often an interesting interpretation of a text that they've held to without actually understanding the text within context of the society it was written in, as well as the context of the rest of the book. So, you know, some education around this is also very helpful. And often what I find is that couples are able to make a compromise because often they do have values that are usually closely resemble one another. I mean, that's why they're together in the first place. There was some commonality between the two of them that brought them together. And even if they have some different interests, they are willing to compromise for the sake of that relationship. And that's one reason why I really love working with religious clients, is because they come to therapy with the idea of, yes, we want to work on this relationship. Yes, we want to make this relationship work because it is something important to us, and not only to our family, but to our faith background and to our culture.
Great. Another question and comment really is, how do you go about? I love your analogy with when the therapist and the client have opposing views, right? How do you go about when you are doing counseling or therapy, and there are clients who ask for interventions that are challenging on your personal belief, right? So personal and professional belief. Like I had a client who came in and wanted conversion therapy. And again, the fundamentals that I think were taken was hold fast by the religious beliefs that the behavior and the thoughts were not appropriate, and very strong religious beliefs. And again, you know, as a clinician, as a medical doctor, I kind of also put on the hat of, if someone is coming in and asking for a medication which is fundamentally researched and it has been shown not to be appropriate. So I took the approach of evidence-based and really discussed the concepts of what the literature, the science shows about certain interventions, and then, you know, progressed to discuss referral. So I think the issue I wanted to bring forward, perhaps for Tali and for Caleb, is how do you address the concept of referral when you, as a provider, as a therapist, as a counselor, are very challenged? You know, sometimes we have this impression that referral is a failure, right? So referral, it's certainly appropriate to separate personal belief from professional responsibility. Just wondering if you have any comments on that, Tali?
Yeah, I'm going to comment from a very kind of personal place, because part of my whole, I would say, journey from being a pelvic floor physical therapist to being a therapist was a lot of, you know, being seen by clergy as somebody who can help get young women who were not developmentally ready for a relationship of intercourse, kind of get them ready for intercourse at the obligated times. That for me presented a conflict in terms of bodily autonomy. And so that also kind of helped kind of create my transition into becoming a therapist. I think that the question has such universal application, because every single one of us, no matter our religion or our backgrounds or our values, are going to be confronted with conflict in our office, whether it's about you know, ethical non-monogamy, or whether it's about gay affirmative therapy versus conversion therapy, or whether it's about interventions even that the clients themselves are not willing to do because of religious restrictions. And we might be thinking, oh, come on, really? So we have that continually. And I think that the answer to those questions really lie, especially as a therapist, in our own self-awareness and our own understanding of our countertransference, which is what comes up for us in the therapy, and making sure that we're able to talk about the idea of conflict. Because when we're talking about sexuality and we're talking about religion, first of all, especially when we're dealing with faith-based populations, we're seeing patients, let's say in their 20s or in their 30s, but they may not have had a normative sexual development process, especially where in communities where there's absolutely no sexual outlet, masturbation is forbidden, and even the idea of sexual arousal can present almost as a trauma, because when you're wired in a way that arousal is to be avoided, and then you get aroused, and then you have to masturbate, that whole process almost becomes a somatic experience of guilt and shame. And that's the sexual development that they're coming to when they're about to get married and they need to be able to function. And so ideas, I think that we will all have issues that press our buttons, whether it's sex out of obligation because it's the wedding night, or whether both partners are ready for that level of intimacy or not, or whether it's restrictions around masturbation that can create this tremendous shame. Our job is really not what we think or what we feel. It's really about what our patients feel and getting them to a place where we can heal the shame, and we can also heal the splitting, because much of the pornography and much of the behavior, which is acting out behavior due to these restrictions, occur in a kind of split off part of their other parts of development. And I think that what Caleb was saying before, I ask about religious values, and you do that because what we actually want to do at the end of the day is we want to get our patients to choose their behaviors, not to just do them in a way that's split off, but to be able to say, you know what, I'm choosing this. Yes, I very much value where I come from, and I value my religion, and I value my traditions, and at the same time, this might be too hard for me, or I don't believe in this part anymore, and I am responsible. And when you choose your behaviors, you have a lot less behaviors that end up in unwanted pregnancies or in boundaries that
Right.
get ignored. So I'm sorry for such a long-winded answer.
I want to get to two other questions, and I think they're really important points of discussion, and I would value your input for this. I'm going to read this question that came in, and this is one, and it's talking about genital cutting of infants and children. And it states that the religious cutting of girls is vilified in Western culture, but religious male genital cutting is tolerated. How do we form a consistent approach that respects religion, but is firm on the right to a full and satisfying sexual life without having important sexual anatomy forcibly removed? How do we support bodily autonomy, genital autonomy, the right of all individuals, male, female, or intersex, to be free from sexual harm, sexual violence, while being respectful of religious culture? Why is genital cutting affecting 5% of girls and a third of boys worldwide not discussed? It's tightly connected with religion, profound effect on the experience of sex and sexuality. And again, we certainly see, male Jews who may experience their circumcision as sexual violence. I certainly think this is such a critical point, and I know we don't have that much time, but I think we need to touch upon it and maybe make that a suggestion for, a follow-up. Again, we have so many other things, and I'm going to throw the other one in because I want you to talk about this. The whole concept of arranged marriage, unconsummated marriage, I think are common issues. So let's tackle genital mutilation first, and then go. I want to make sure we talk about unconsummated marriage. Caleb, do you want to jump in first, and then we'll shift to Tali?
Yeah. So foreskin and unconsummated marriage. Maze, I don't know. Okay, so let's.
You do foreskin. I'll do unconsummated marriage. How about we?
Perfect.
We share
I was hoping we could change this. So I would say that as an Orthodox Jew, I would say there is a great distinction between circumcision of males and female genital mutilation. Female genital mutilation often takes place in these contexts in order to, based on a false belief that by doing such, this would relinquish female sexual desire. So the narrative and approach in which it is done is something that is completely different to begin with. And of course, with female genital mutilation, which takes place at different ages, depending on which culture it is in, can also sometimes be the result of certain sexual behavior and wanting to, if in some societies when a female has been sexually active, that is when it takes place, as opposed to earlier on, which takes place as well, right? But the whole entire idea and the concept is to curb female sexual desire, need, and interest. So this is a lot different than circumcision among men. Within the United States, circumcision among men was adopted by most Christian faiths as well, simply from a sexual health perspective, ideally, for the reduction in transmission of STIs and things of this nature. So I would say there's a big distinction between the two. I think in either case, I think education on the topic is very important. And I'll tell you, in Judaism, there's a lot of discussion about the circumcision topic right now. There's a lot of argument and contention on that very topic. And that's why I, again, think that education is extremely important for that as well.
Okay. I think that I'll jump right into the unconsummated marriage, even though there's what to say about circumcision. But, when I was researching unconsummated marriage, I've written several papers and co-written papers. And in doing the research, it was interesting to me that most of the papers, pretty much all the papers on unconsummated marriage came from the Middle East. And I had written about some case studies on unconsummated marriage in Orthodox Jewish society. And I think that the common factor is the idea of there not being premarital sex, and there being an expectation for sexual intercourse to take place at a specific date, when the amount of both emotional and physical intimacy before marriage may vary from almost none at all to everything but. And so in doing so, I think that the ethical issue that comes up, and it's the same kind of issue that you brought up before as a practitioner, is the idea of, does it have to be? Because we value autonomy and we value the ability to, we value consent, and there are levels of consent. I think it's very interesting that the Rosemary Bassan model, which is about, desire, which is receptive, has been very popular in traditional faiths, because traditional faiths will tend to provide sexual education to wives, whether it's Mormons or Jews or otherwise, that sex is an important thing. And you actually guard your husband by giving him the sex that he wants and needs, and protect him from spilling seed in vain or from masturbation. And so the Bassan model is a great model to sell to religious faiths. Not that it's not a consensual model. It is a level consent. It's not as high a level, let's say, as enthusiastic consent. It's a second level, which is not, I really want to, but I will. And I will because I know that I'll enjoy it. So that's great. But then there are lower levels of consent. For example, I should because, I'm obligated to, or all these, messages, or whether it's because my husband will be in a better mood. I mean, we're still in a consent model where I'm choosing it. But then it gets to levels of, well, I have to. I'm not allowed to refuse my husband if he wants to have sex with me. And that already begins to become a huge conflict, because that's already a possible human right violation, and what's interesting is, at least when it comes to your Orthodox Judaism absolutely does not allow sex to occur without mutual consent. So what Caleb was talking about before, about how the basic tenets of religion get modified or moderated by culture. I think this is a very good example, that culture has come along, especially mysticism and other cultures that have come by and created these beliefs about the obligation to have sex. But in the biblical texts, and there is no such there. In fact, most of the statements in the Talmud, or most of the statements that have to do with sex, look at sex as being, as of course needing to be mutual and consensual.
Great, thank you. We have some time for some other quick comments. Dr. Jacobson, this is certainly directed to you. You mentioned the concept of religious trauma. So the participant is wondering your discussion and your points about religious or spiritual abuse and the development of compulsive sexual behavior, or otherwise, or other sexual issues that may develop because of religious trauma, and how does it impact the treatment and recovery?
Yeah, that's a great question. So a few things on that. I do make a distinction between spiritual abuse and religious trauma. Okay, these are two separate topics that are both equally as difficult to deal with. I would also say that I think that it's important, going back to what I discussed earlier, to distinguish between what a religion actually teaches and a particular religious community teaches. And this is a big distinction, because I do follow a very holistic perspective in working with clients. And so I think for them to have some type of spiritual development or some type of congruency with their spiritual and religious faith is important, whether they choose to practice or choose not to practice. I think they need to be empowered in making that decision themselves, instead of having that decision taken away from them because of trauma or what a therapist tells them or whatever the case may be. So I often liken it to the fact that as a sex therapist, we would never tell a client who had experienced some type of sexual abuse that they never want to be in a relationship and never want to have sex again. We would never give them that advice. And so I think we also need to be careful for them that we don't give them the advice, well, you just never want to explore religion or spirituality in any type of way, because I think it is very helpful and can be part of the healing process for them. Very often with religious clients, though, there is some type of compulsivity towards certain sexual issues. And of course, there are plenty of sexual dysfunctions that come with religious beliefs. In fact, it's interesting to compare sexual dysfunctions compared to, whether like in Orthodox Judaism, we see a lot of early ejaculation, for example. We see a lot of female sexual pain, which is often vaginismus, for example. Whereas in more Christian communities, I found that clients often have more delayed ejaculation or, ED, for example. So I think that it is important when clients come in that we first help them to prioritize what's going on, because often there's all these competing views, right? They come because they're upset that all they can think about is masturbation, right? Maybe they have a compulsivity towards masturbation, or that's what they feel. But that compulsivity really comes from the fact that their religious practice or religious belief has forbidden it, everyone in their culture, everyone in their community continues to tell them, don't do this. And so they are struggling not to do this thing that they feel that they should do because it's a part of our natural sexual expression and our sexual development. And so oftentimes I feel it's an idea of perspective, because this idea is getting closer and closer to you and it's all you can think about, and you all end up doing it, and it creates this vicious cycle, which is traumatic in and of itself, of I don't want to do it. I feel it's terrible if I do it. It's all I can think about. I want to stop myself from doing it, and I continuously do it. And I cannot tell you the number of men who come with issues related to this. And that's why I think it goes back to, what are your values around sex? What does your faith tradition teach? And what does the text actually teach? So why does your faith tradition teach this? And what does the text actually teach? And teaching at the university, I'll tell you, even among Christian students, which is mostly what you have in theology faculties in Germany, is the number of clients who often come up to me, I think I'm masturbating too often. Well, why shouldn't you do that? Well, the Bible says this. Well, tell me where the Bible says this. Let's discuss the text. Let's look into it. So I think it is, I don't expect every clinician to be biblical scholars in any sense, but I do think having some knowledge, or at least some references that you can go to, or colleagues that you can refer to who are knowledgeable on this subject, is very helpful in getting the client the information that they need to actually make informed decisions about their values and their practices.
Great. So I want to take the opportunity to thank my colleagues, and I want to give everybody the opportunity for one last comment before we wrap up. And I do apologize in advance. I think this is a testament to the importance of the topic. We've had multiple questions. Unfortunately, don't have time to answer them all. We had nearly 200 participants on our first WebEx of the year, which says something to the topic. Many diehards stay till the very end, which is something very exciting for me. So Tali, some high-level closing statements, 1 minute or less.
Well, I just think that one thing we need to remember is that level of religiosity and adherence may actually be a protective factor in some of these, in the resilience to the development of trauma. So if you really believe in what you're doing, you may be less likely to develop trauma. And I think that there are some data to back this up. Just one thing as a clinician, we deal with conflicts between sex and religion all the time. I have a podcast with a rabbi called Intimate Judaism, and I invite listeners who are interested in the conflicts between Judaism and sexuality to listen to our podcast. Thank you.
Great. Caleb?
Yeah, I also would like to state that as a practitioner, we do hold certain views and ideas about sex, sexuality, and gender that could be very conflicting to our clients. And our clients do come with conflicting ideas of their own about how they feel sexually and what their faith says and what their faith teaches. And I think we can sometimes create a problem where there is no problem. If a client says, my faith teaches this, but I don't really feel this way, but I want to adhere to my faith, and they don't have any anxiety and they don't have any negative effects to that, I think we shouldn't create it to be a problem when it isn't. When they're not having any side effects, I think it is the clinician or the client's right to hold to those beliefs and to live in a way that they feel is right and empowering to them. I would say I do have a book on this topic of sex therapy with religious clients, primarily looking at Jewish, Christian, and Muslim communities, that it will be published in a few months by Routledge for those who are interested. And I do quite a bit on Instagram with this topic.
Great. And I want to just kind of go back to the basics. And, I think for most of us, we want to practice what I would call precision medicine. We want to look at the individual as a unique person on a journey for sexual health and wellness. And just as we tailor the treatment, we need to tailor our history and assessment. And getting back to the fundamentals, I think many of us are not even asking, right? So ask. You don't know that there's a problem unless you ask those specific questions. And I think for me as a clinician, that would be probably the most important take-home message. I will let you know we've had many comments about more interest. I know the academic and scientific chair was on the webinar, and there is really a thirst for this, and discussions and case studies. And of course, you know, we did have some case studies presented, but we did opt for trying to address as many questions as we could. So again, apology in advance for not addressing your questions. Again, we would like to thank the ISSM on behalf of myself, Caleb, and Tali. We want to thank you all for participating this morning, noon, afternoon, early morning, evening time. And again, thank you so much for your participation. It really is a very big honor to be invited to speak and to see so much interest around this very interesting topic.
Thank you, Dr. Krishman. This is wonderful to listen to you and your esteemed faculty speakers. Really, I would like to thank the ISSM again. I would like to echo your comments. And really, it's been interactive, phenomenal session on very important topic. I'm a urologist. I see a lot of patients in male and female sexual problems, and this topic has been, and presentation has been eye-opener for me. I really learned a lot, and I'm also listening to the comments here on the chat box here, and one comment said we have a huge problem related to sexual health due to religious reasons. We cannot even discuss it with patients openly. It's very risky to our own lives. So to that extent, it's very important topic, and I really thank you, Dr. Tali Rosbaum, Dr. Jacobson, for a wonderful interaction session. I have a few minutes to really announce the next webinar. The ISSM webinar will take place on February 16 at 3 p.m. UTC time. That'll be 9 a.m. Central Time, US. And we'll be on what is normal when it comes to sexual function. With that, I'd like to call this webinar to an end, and I'd like to thank you all for participating and being interactive. Thank you so much.
Thank you.